Happy to have with us here at ASCO 2011 Dr. Rita Axelrod from Thomas Jefferson University in Philadelphia, PA. Thanks for being with us.
My pleasure to be with you today.
So you're part of a very exciting phase 3 trial. What can you tell us about it?
Well, RTOG 0522 is a pivotal phase 3 trial conducted by the Radiation Therapy Oncology group, and it was designed to test the hypothesis that for patients with locally advanced head and neck cancer, adding the drug Cetuximab or Erbitux to standard high-dose radiation and Cisplatin would change the outcome for patients and improve local regional control and or overall survival. Let me tell you a little bit about this trial. One of the most extraordinary things about it was the large number of patients who were accrued in a record amount of time. Over 900 patients entered this study between November of 2005 and March of 2009, one of the fastest accruing NCI trials ever. How did this happen? That by itself is truly extraordinary.
So the design was absolutely critical to the success here.
The design was simple. It used a very standard form of treatment for patients with locally advanced head and neck cancer. High-dose radiation therapy with Cisplatin every 3 weeks given for up to 3 treatments. And it matched that with the same therapy given with the addition of Erbitux or Cetuximab given as a loading dose, and then weekly for a total of 8 doses, including the loading dose. One of the ways that this trial became successful was that the principal investigator, Dr. Kian Ang, was clever enough to not only in study trial design, but to obtain the consensus of those who would participate in the trial, so that before the trial ever began, before the study design was finalized, there was a poll, a physical poll of those members of the group who could contribute patients. Will you contribute patients to this study? Do you believe in this design? Do you feel comfortable in this design? And as a result, the trial accrued much more quickly than anyone had anticipated. Initially, the trial was expected to require approximately 700 patients, but patients did much better than expected. That means there were fewer events or unfortunate events that might cause an end to the trial or could show a difference between the arms of the trial. We now understand that this was probably confounded by a change in the causation of oropharyngeal cancer. Traditional head and neck cancers were caused by largely exposure to 2 carcinogens, tobacco and alcohol, and other pollutants. We now know that the human papillomavirus has played an increasing role in the causation of head and neck tumors, and you can see head and neck tumors in patients who are not smokers, who are not drinkers, and you can show evidence of human papillomavirus within the tumors. These tumors tend to have a much better prognosis. We are still exploring the interaction between HPV-related tumors in the oropharyngeal area and other more traditional carcinogenic factors like tobacco smoke and alcohol. So this trial actually asked questions about toxicity, what toxicity would be added by Erbitux or Cetuximab. Cetuximab with radiation is much more effective than radiation alone for locally advanced head and neck cancers. And the beauty of adding a drug like Erbitux or Cetuximab is that you don't have the traditional toxicities of chemotherapy. So it is a very appropriate therapy, for example, in patients who may have renal failure and cannot tolerate a platinum-based compound, in patients who have significant hearing loss, who would have their hearing injured further by a platinum-based compound, in patients who have a poor performance status, who might not be able to tolerate traditional chemotherapy. So the addition of Cetuximab or Erbitux into the armamentarium of drugs for patients with head and neck cancer has been an important step forward, particularly when added to radiation. This trial asked the question of whether there would be an additive effect between cetuximab and radiation.
What can you tell us about the results of this study?
Unfortunately, the trial did not show an additive benefit for the addition of Erbitux to radiation therapy with cisplatin. And I don't think we really understand why that happened. We don't understand whether it's because the radiosensitization mechanisms might be similar for Erbitux and cisplatin. We don't understand if there might be some as yet undiscovered interaction between Erbitux and cisplatin. But we do know that when Erbitux or cetuximab is added to cisplatin, clinical trials in head and neck cancer have shown an advantage for the addition of cetuximab. That benefit is not as great as the additional benefit that's seen when you add cetuximab to radiation therapy alone.
Doctor, I know you have further analysis to do, and you have a special concern for a rising epidemic among younger patients.
Younger patients are an important cohort of patients with oropharyngeal cancers who have a history of never using tobacco or lightly using tobacco and not using alcohol or only socially using alcohol. The traditional head and neck cancer patient in the past was someone who was much older, who had a history of smoking to excess and drinking to excess. And we know that those patients tend to have multiple primary aerodigestive tumors. That is, they may quickly develop, 1 to 3% per year may develop, another primary tumor in the head and neck or another primary cancer in the lung. So these patients are under constant surveillance. We are still learning about patients who have HPV positive tumors, and we are also learning about the interaction between HPV and tobacco smoke, and these analyses are being carried out. Subset analysis from this RTOG 0522 trial involves evaluation of HPV status of oropharyngeal tumors, and that data is still coming in. But so far, there did not appear to be a difference in the response rates between those who had Erbitux and platinum with radiation and platinum with radiation alone. So we'll have to see what the final analysis will show. There may be other samples that have yet to come in. The analysis has not yet been completed. One of the things that happens when patients participate in a clinical trial such as this is that the quality control for those patients improves. The radiotherapy techniques and the field coverage are monitored by the process of the protocol. The delivery of the chemotherapy and monitoring for toxicity are monitored by the protocol for both platinum and for Erbitux. Untoward or unusual toxicities are managed in a standard fashion. And of course, if there's a safety signal, a protocol can always be changed. In this trial, there was no safety signal, and there was no difference in death rate. There was no difference in significant adverse events, except for mucositis in the patients who received both Erbitux and platinum, and for skin reactions in patients who received both Erbitux and cisplatin.
Dr. Axelrod, thank you for coming by and sharing your exciting work with us. We appreciate it.
It was my pleasure to be here today and to share this really important information with you.
Keep up the good work. Dr. Rita Axelrod from Thomas Jefferson University in Philadelphia.